Good afternoon, everybody. Today it's my pleasure to introduce Dr. Marco Pahor, MD. He is professor and chair of the Department of Aging and Geriatric Research and also director of the Institute on Aging at the University of Florida in Gainesville. Dr. Pahor received his medical degree at Catholic University in Rome and completed his fellowship in internal medicine and geriatric medicine also at Catholic University. He has over 35 years of experience in aging research, including population-based cohort studies, multidisciplinary clinical translational research, and also randomized clinical trials. His area of research has focused on disability, physical activity, and physical function, as well as the role of inflammation on mobility in older adults. He is the principal investigator of the LIFE study, which is a very large multi-center trial to examine the effect of physical activity on mobility disability in older adults. So please welcome Dr. Pahor. Thank you.
Hey. Thank you very much. It's my great pleasure to be in San Antonio. I'm really amazed by the wealth of research that is ongoing here and the major challenge of translating from basic science to clinical arena. That's what we are trying to do at our place as well, but not at the level that's going on here. I will talk about inflammation, low-grade chronic inflammation, and how is it relevant in older adults for geriatric outcomes. And then I'll talk briefly about a few trials that address abating or averting inflammation and how that can impact on outcomes as well. So I will talk briefly about various interventions, and many of those are being tested here at the Barshop Institute I've seen this morning. And talk about a few trials, a couple that have been completed, the LIFE study, which Sarah has mentioned a second ago, testosterone trial, and then one that is ongoing, the Energize trial, and the TAME, which is a metformin lab trial, which is in the planning phase. So past, ongoing, and possibly future. When we talk about low-grade chronic inflammation, there is virtually in medicine any condition that is associated, any pathological condition is associated with some level of inflammation. And here is a long list, and I would challenge anyone here to name any condition that is not related to inflammation. Probably some genetic alterations, but again, even those have been found to be related to inflammation. So the question is, if inflammation is a risk factor for so many conditions, is it a specific factor that can be a risk factor that can be prevented or reduced and consequently translate in an impact on outcomes? I will focus primarily today on disability and impaired physical function, that is really a focus of our research, but also mention about other areas such as cardiovascular disease and cognition as well. So when we talk about low-grade inflammation, we are talking about very low levels that typically are not associated with acute inflammatory conditions. So here is a distribution in free inflammatory markers that are mostly used in epidemiology and clinical research. C-reactive protein that is now approved by the FDA to identify high-risk cardiovascular disease, and interleukin-6 and TNF-alpha. And this is in a health ABC cohort, a cohort of 3,000 older adults who are well-functioning, living in the community. And the levels here you see there are C-reactive proteins in a free, the average, the median is 3 milligram, actually 1.68 milligram per liter, and the mean 3 milligram per liter. The interleukin-6, 1.8, which is picograms per milliliter, and TNF-alpha, 3 point. So it's a single-digit units In acute inflammation, we are talking about hundreds of thousands of units as opposed to single digit. So it's a very different situation compared to acute. Also, if we look at the correlation, how these markers change over time, how stable are, here is measured in the same cohort at 1 year and 2 years of follow-up. And here's a correlation of C-reactive protein, interleukin-6. It's pretty stable over time. As compared, for example, for glucose levels or cholesterol levels as more traditional markers or health-related markers, it's very similar correlation over time. This is a famous study by Paul Ritker, published several years ago in the New England Journal of Medicine, showing quintiles of high-sensitivity C-reactive protein and the cardiovascular event survival probability. So those with the highest quintile have the highest risk. Most of the epidemiologic studies I will show you are pretty old. It's a research that has been conducted in the last 20 years. And what I want to show you now in the transition phase of an intervention phase. These are also from a study we've done in a health ABC cohort looking at the cardiovascular events we published in Circulation several years ago. Look at the interleukin-6 and risk of coronary heart disease events, which was highly significant. And interestingly, in older populations, the interleukin-6 is a much stronger and much more reliable marker than C-reactive protein, which is used in clinic and approved primarily for middle-aged populations. But typically we have found in all our studies that interleukin-6 is the most consistent marker. Here we look at cardiovascular events based on coronary heart disease, stroke, and congestive heart failure. If C-reactive protein, interleukin-6, or TNF-alpha are elevated, so if one marker compared to no marker elevated, if 1, 2, or 3 markers are elevated, the risk increases exponentially for all of 3 conditions. And here is a study that was also published from a health ABC cohort looking at cognitive cognition. And here again, higher level of interleukin-6 C-reactive protein are independently associated with a decline in cognitive function in older adults. So this is like a conceptual model looking at sarcopenia as a central outcome, loss of skeletal muscle mass and function, ultimately leading to loss of mobility and higher risk of disability. And several, as I mentioned in my first slide, most of the pathological conditions are all associated with increased pro-inflammatory cytokines, leading to increased apoptosis, increased proteolysis, reduced protein synthesis, and reduced regeneration, which lead to myocyte loss and ultimately to sarcopenia. Frailty is another important factor that is a key geriatric outcome that has been operationalized by Linda Fried, looking at people who have slow walking speed, reduced strength, fatigue, and weight loss. And the prevalence of frailty in older women enrolled in the Women's Health and Aging study here is increased with increased level of interleukin-6 again. And here are those who are frail, those who have 3 of the 5 criteria present, and the pre-frail who have 1 or 2 criteria. The key factor is which is a threshold according which we could demonstrate a higher risk. And that's a study we published several years ago from established populations of epidemiologic studies of the elderly, showing that really the increase, the risk of mobility disability increases exponentially with increased interleukin-6 at levels higher than 2.5 picograms per milliliter. So that's kind of course, any threshold in clinical practice is an arbitrary measure because most of the factors are on a linear curve in terms of risk. But here is traditionally 2.5 is a number that we can retain as a threshold for increased risk. Here again is from a health ABC cohort looking at the C-reactive protein and the risk of mobility disability, so inability or difficulty walking 400 meters, according to C-reactive protein, interleukin-6, and both are associated. Those who have incident mobility disability have a significantly higher level of C-reactive protein at baseline and also of incident disability. TNF-alpha is kind of less, even if it's significant here, is less associated. These were kind of univariate analysis, and these are multivariate analysis adjusted for several factors that are independent risk factor for mobility disability. And here again, we show that interleukin-6 is the one that has the strongest association with incident risk. Here again, it's a similar analysis I showed earlier for cardiovascular risk, looking at how many of the markers, 1, 2, or 3, C-reactive protein, IL-6 or TNF-alpha are increased, and whether there is an increased risk of mobility disability. And here again, it increases with a number of factors that are. That's another population in Italy, the Inchianti population that comes from a region where the Chianti wine is done, where people are pretty healthy, done by Luigi Ferrucci, who is now director of intramural program at NIA. We showed also again that the physical performance score is significantly associated with increased level of interleukin-6. That's an analysis that we've done on changes from a number of studies, a meta-analysis of multiple studies looking at chair rise, 4-meter walk, short physical performance battery, which is a composite score of ability to raise from a chair, balance test, and walking speed on a 4-meter, or strength. And here again, there is a significant association with a C-reactive protein, but even stronger for interleukin-6 with impairment of these markers. So, if inflammation and interleukin-6 are important risk factors for cardiovascular disease, frailty, loss of cognition or dementia, and impairment of mobility, what are the interventions? So, can we intervene targeting inflammation to avert these outcomes? Well, as I mentioned, virtually any disease is associated with inflammation. In the same way, any drug that is effective on these diseases is also shown to have anti-inflammatory properties. But here we are facing a problem of a primary prevention of an outcome in older people who are frail, and really we're not treating a specific disease. So we are looking at a number of criteria how to select the markers that we can target and intervention that we can apply in a large population. So here, like a few criteria that we kind of prioritize for this selection. Safety, tolerability, and acceptability are the key criteria. Because for example, we tried to test a low-dose methotrexate, which is a relatively safe drug at low dose, have anti-inflammatory properties, and is now being tested in a SEARCH trial, a large trial on cardiovascular disease by Paul Ritker. He has no trouble recruiting because he's targeting people who are middle-aged, have heart disease, and are high risk of a second event. So we would do anything to prevent the disease, but prevent another heart attack. But we are targeting older people who are frail, slow walkers, to improve mobility. No one wanted to take it. When we proposed methotrexate in 6 months, we were not able to randomize any single participant. When we went to the doctor, they said, no, this is a dangerous drug, you're not supposed to take it. You better just do your exercise or whatever. So safety acceptability is a key. Of course, we need to show a benefit on inflammation and possibly on physical performance and skeletal muscle. We want to look at innovative interventions. As I will show in a second, physical activity is an intervention that shows to be effective, but we want to know other additional pharmacological intervention. We want to make sure that there are biological mechanisms that are plausible for these drugs or interventions to be effective. And the other point, they need to be practical and affordable. So we consider, for example, Mediterranean diet has demonstrated to be highly anti-inflammatory, especially like olive oil has a compound that is similar to ibuprofen. It's strongly anti-inflammatory, nuts. But the challenge is to go in our communities with older people who are used to use American food now you need to use, would be really challenging and very costly intervention, so not really practical to modify practice. And affordable. There are some drugs that are highly effective but so expensive that would not be efficient to be used in a large population. So these are criteria we were looking. And here are a number of interventions that we have considered on a pharmacological, ACE inhibitors and angiotensin receptor blockers. Actually, I'll focus on those, on losartan. We have a trial ongoing on that. Aspirin, there's a trial ongoing now, the Aspirin, large multi-center trial. Anti-TNF-alpha, L6, L1 are kind of toxic and costly, not practical. Chloroquine and colchicine also have adverse effects as well as the COX-2 inhibitor. Metformin is high on the list, and I know there are studies going on here, and there are some being planned. I just mentioned about methotrexate. Myostatin inhibitors are used by industry, but again, they're quite costly. Rapamycin is a hot intervention, and again, doesn't seem to be very practical or safe to be used in a large-scale trials, but that's still under investigation. NSAIDs, of course, have major adverse effects. Statins have muscle negative effects on the muscle, so it's not been. Thalidomide and thiolidinediones are being possibly studied, salsalate as well. Hormones, number of hormones are being considered. Growth hormone, and all those have shown to have anti-inflammatory properties. Primarily, growth hormone has been very disappointing, and growth hormone secretagogues didn't really show much effects. Oxytocin is hot now, and I know there are a number of sites that are being studied, including ours. I don't have data yet, though. I will talk about testosterone study, and SARMs as well are being studied as well. Nutritional supplements are very popular. A large number are being studied in various studies. We have one on resveratrol. Vitamin C has been disappointing as well, vitamin K and E. Vitamin D studies are ongoing as well. NAD Plus has been a lot of focus on that product. Not much data yet. Cucurma also, we have a trial, a pilot going on which I don't have data on this. And omega-3 polyunsaturated fat acids fill very much the criteria I illustrated earlier, and I'll show you a trial that is ongoing with fish oil right now. And of course, the behavioral and surgical interventions, diet, low calorie is a highly anti-inflammatory, as I mentioned, also Mediterranean diet. Physical activity, I will show you some physical activity results as well. So here are a few trials we've completed in the past on physical activity. That's the ADAPT trial, on which we randomized older adults with osteoarthritis of the knee who were overweight and randomized them to either attention control, to exercise, which was a combination of aerobic and resistance exercise, low-calorie diet, or a combination with diet and exercise. And here's a change in interleukin-6 after 1.5 years of follow-up. The red line shows a control where naturally in older people over time, and that's a natural process, pro-inflammatory markers tend to increase over time. Here the yellow line shows the exercise, which showed a significant reduction. Diet is more potent than exercise alone, but the combination of diet and exercise was the most potent. And this translated in the same way in physical performance, such as a 6-minute walk performance, which was much best result paralleled with interleukin-6 with the diet and exercise combination. The LIFE study is a study of physical activity in older adults. We conducted a pilot study in which we measured 400 people followed for a year, 12 months, who were randomized to a combination of physical activity, combination of aerobic and resistance exercise, and health education. And here we show interleukin-6 changes over time, and see the baseline was right at the threshold, the average at the threshold of people of a high threshold of high elevated interleukin-6. And the dotted line shows a successful aging of health education that tended to increase over time, and the exercise actually prevented such an increase, and there was a significant difference between the two groups. But most interestingly, if you look at the people who were in the highest performance group, so the short physical performance matter above 7 shows the least compromised, physically compromised group. Well, this one was a group the most compromised. And so we show first at baseline, the least compromised had the lower interleukin-6 levels at baseline. But really exercise didn't do much in terms of anti-inflammatory effect. And while in the most compromised, those had the greatest effect in increasing, but the exercise also was most beneficial. So here the point is that intervening in people who are not high risk probably will not show much of an effect. And that may explain why many studies who look at reducing inflammation with some interventions didn't show anything, no benefit, because people didn't have inflammation at baseline. So there is nothing to reduce there. Yeah?
When you talk about exercise,
what are you doing?
Yeah,
So this was a moderate intensity physical activity, primarily walking. So people were asked to walk at moderate intensity, half an hour per day, 5 days a week. So they were coming twice a week at the center, and the other 3-4 times at home. Twice a week resistance exercise, primarily weight lifting of ankle weights. Very simple, no machinery, was really walking on a track. And the exercise was designed to be implemented in the community in any environment, no need of special equipment or also some stretching exercise. So it was a combination. And but not high intensity. This is the same study, just a different analysis, looking at people who had low interleukin-6 at baseline, and again, you don't see any effect. But those who had high interleukin-6, so above, so as I mentioned earlier, 2.5 is a limit for elevated. That's where you see the difference of intervention. Here again, a reduction of physical activity versus successful aging. So that was a pilot, and we later conducted a much larger study in which we could really measure hard outcomes. Actually, in this larger study, in the pilot, we randomized 400 people. In the large study, 1,600 followed for 2.6 years on average, so between 2 and 4 years. And we were looking at a hard outcome, whether a structured physical activity or health education program is more effective in reducing the risk of major mobility disability, so whether they can or cannot walk on a 400-meter task. So study started in 2010 and ended in 2013, so it was a 4-year range. Here are 8 sites across the nation. Florida, we had a coordinating center, data management at Wake Forest. And here is a primary outcome. So it was measured objectively whether people can walk between 20-meter track. And we looked also number of secondary outcomes, ideal disability, cognitive function. I will show you results on these outcomes as well. The analysis on interleukin-6 on this cohort is ongoing right now. So we have the same, the intervention was identical in the pilot and the larger study. So we expect that this one as well had the same result. So the major mobility disability occurred almost in a third of the subjects. 32% had the primary outcome of inability to walk for 100 meters, and 70% persistent. The measure was, the outcome was measured every 6 months. If they failed 2 months in a row, it was considered persistent. And this was published in JAMA a couple of years ago, which we showed that significantly the physical activity reduced the major outcome by 18%, which is very similar to major prevention trials on cardiovascular disease reduction. We can observe, like with statins, is around 20% reduction in cardiovascular events. So it's a similar range of magnitude. And regarding the persistent, reduction was hazard ratio 0.72, so about 28% reduction, so even greater effect on persistent reduction. If we look at the subgroups, and this is interesting, the effect, if we look at those who have a low short physical performance battery, so the highest risk, that's where we found the greatest benefit. And so the results on the major outcome parallel the results we found on inflammation. Remember the slides I showed earlier, the highest effect on anti-inflammatory effect was those who were highly impaired. And same thing in those who are slow walkers. Typically slow walking speed below 0.8 meter per second identifies a very high risk group of outcomes. So very recently, we reanalyzed the data. This was published in the Annals, just a couple of Annals of Internal Medicine, just a few weeks ago. Instead of looking at the first outcome, we look at the overall burden of disability. So how much time during the whole follow-up time the people are in a disabled state versus being able to walk. And here is, again, the results are very similar. So there is an overall 25% reduction in risk of being overall disabled during the follow-up. One key question is, how much does this cost? Because intervention can be effective, but from a public health perspective, is it cost effective? And so we analyzed the cost of each program. So the cost of a health education was about $1,000 per participant on average versus $3,300 for physical activity. And if we look at the incremental cost of quality-adjusted life years, which is a standard measure for cost-effectiveness analysis, the cost here was $49,000 for one quality-adjusted life year reduction. And this is the same in the range of antihypertensive treatments. How much does it cost to reduce one quality-adjusted life year by reducing hypertension, reducing cholesterol? It is deemed to be cost-effective when the range is between $20,000, $30,000 to $100,000 in that range. And here we are right in the median, $49,000. Also for reducing one disability year prevented, also it's about $42,000. So the intervention is cost-effective. Yes?
So this is why the insurance companies that are taking over the organized care for Medicare are including free gym membership with special trainers.
Well, that's our goal, to have a CMS pay for this type of intervention, which we don't so far. They're not paying. I mean, Medicare, as far as I know, they don't pay for exercise interventions. I mean, some insurance program, if you have a Medicare Advantage or they would support exercise programs, but Medicare.
They're paying for it through these organized healthcare. Scott White does it, all these other people, they contract for Medicare benefits. What do they call it?
Right.
Managed care, whatever it is.
But as far as I know, as a primary, like Medicare, even after a DPP trial, Medicare pays only for one counseling, nursing counseling for diabetes prevention, as far as I know. Am I right? You don't know. But I looked at that because our goal was really to make sure. And so the point is that in geriatric medicine, if we are going to succeed anywhere, I think it's in the prevention area. When we are too far away on a trajectory, I think the efficacy is much less than we could achieve with a preventive approach. This is a kind of complex slide which I will summarize on cognitive outcomes. We look at a very broad array of measures, and really nothing came significant. We had no main effect on cognition from exercise, and we can discuss, I can respond to questions why this has happened versus other studies have shown that. But when we look at the subgroups on executive function, and we look at those who are most compromised with a short physical performance battery. Here on the right-hand side, they favor intervention, so there was a significant interaction and a significant effect on executive function in highest risk group. So the most frail people had some benefit on executive function. We also looked at serious fall injuries, so falls accompanied by fractures. Overall, no effect. But if we looked at men and women, we found a significant effect in men and no effect in women. Again, I don't know why this has happened. We cannot explain it. If someone has ideas, we'll be glad to learn it. But this was a post hoc finding. So we looked at cardiovascular disease events. Again, no overall benefit. But if we look at the subgroups, here again, those with a short physical performance battery had a significantly better than those that were most performing. Again, the highest risk group had a greater benefit than a low risk group. So I mentioned earlier about testosterone, which also has anti-inflammatory properties. And there is so much debate about the potential benefits of testosterone and whether it is effective, of course, on sexual function, on physical function, on cognition, on vitality. This is the largest trial that has been ever conducted, as far as I know, on testosterone in older men. Most of the issues that have happened before is that testosterone was applied in people who had normal testosterone levels. So here was really a replacement in people who have a low testosterone. So they need to have less than 275 nanogram per deciliter. And so we looked at the 3 trials. One looked at the sexual function, physical function, and vitality. So people to enter in these trials need to have low testosterone and symptoms in one of these 3 areas, either sexual dysfunction or be slow walkers or have low vitality as measured by fatigue scale, so express fatigue. Here's the effect on walking ability, which was kind of interesting. The curves were pretty much parallel over 12 months of treatment. They diverged really at the end of a follow-up. The primary outcome looked at only in people who had slow walking at baseline and who could increase by 50 meters the 6-minute walk. So it was powered for a 50% increase in 50 meters, which was very was kind of underpowered, and we were looking at increasing 50% was, I haven't ever seen a study that increased an outcome by 50%. So here it shows an increase of 40%, which didn't show significance. But if we look at all participants, there was a 76% increase and highly significant. So probably this non-significant effect was due to underpowered of the trial. When we looked at sexual function, interestingly, here the effect was opposite. It was highly significant effect to start with. Everyone felt better. But after 1 year, the 2 curves tend to converge. And at the end, was not people on testosterone didn't really do better. When we look at vitality and fatigue scale, the effect was very, very minimal. People didn't feel stronger with testosterone. So I have a couple of more trials I want to talk about. Energize is a trial specifically targeted at reducing inflammation in older adults. As I mentioned earlier, we have quite a bit of epidemiologic evidence that interleukin-6 is a strong predictor of slow walking and mobility impairment. So the question is, if we avert inflammation, can we really improve? And that's what this study is trying to respond. We have 5 sites. It's a pilot study, so 300 people are being randomized, followed for 12 months. And we are looking at placebo versus losartan, angiotensin receptor blocker. As you remember, the criteria we looked for selecting the drugs, they need to be safe, acceptable, low cost, and have evidence that they reduce inflammation. So we choose losartan and fish oil. These were really the 2 drugs that, or 2 types of interventions that came on top of the list. So we want to see first if we can improve inflammation and walking speed. So there are a number why these drugs can work. Well, there are several factors that are may be related, either acting on chronic diseases such as cardiovascular disease, diabetes, and osteoporosis, on which losartan can be beneficial. Can be directly related to sarcopenia, averting sarcopenia because of averting inflammation, or directly related by NF-kappa B activation and cytokine reduction, loss of mitochondrial function, myocyte apoptosis or muscle regeneration, and pro-inflammatory lipid signaling. These are all factors on which both drugs can act. Or diet, of course, omega-3 can be one diet factor, and endogenous factors such as oxidative stress, subclinical disease burden. Really, this study is not designed to identify the mechanisms, but there is quite enough evidence that they can really work in reducing the risk of mobility disability. So these are, again, the same criteria I mentioned earlier. And we looked at this several numbers of drugs that could be tested. But if you look at those who are safe, tolerable, acceptable, reduce IL-6, improve physical performance, are innovative, have a mechanism that and are practical and affordable, only those two have pluses in all boxes. That's how we came up. Maybe there are others that can emerge, but that's what we're testing. ACE inhibitors in angiotensin receptor blockers have an excellent safety profile in hypertension, heart failure. ACE inhibitors may be less tolerable, and so losartan is prioritized because it's low cost. It's a generic. There are new angiotensin receptor blockers, but highly costly. Omega-3 and lipoic acid both reduce interleukin-6. Omega-3 shows anti-inflammatory effects and improves walking speed in women and improves strength. So we hope that, and is widely available and really low cost. One issue with recruiting trials in low-cost drugs that people say, well, I can just buy it. Why would I come to your trial? So that was a difference. For example, when we ran the testosterone trial, we had people driving 130 miles to come to our site to get their testosterone because it's very expensive. So the recruitment was very successful there. Here we have some problems, for example, for losartan, because it's so widely used. It's the most widely used antihypertensive drug. So when you get people to your clinic, they're already taking the drug, so you can take them off. So it's a challenge in recruiting a specific arm. So it's really important to have retention and recruitment strategies to keep people involved and be in the trial. We consider also behavioral intervention. I just mentioned earlier about Mediterranean diet, which is highly effective, but it's really too cumbersome, too complex and costly to implement. So it's a double-blind, placebo-controlled trial, 2x2 factorial design. We have 1 year of recruitment and 1 year of intervention. So right now we are just about halfway in recruitment. So it should be done by early summer, end of the spring, and then maybe next year I can tell you what happened. Maybe nothing, or maybe highly promising. So we start with very low dose of omega-3, 1.4 gram, and we may increase it to 2.8 grams, which is pretty high dose. I tried it all myself. It doesn't give blurb, like fishy taste. It's purified Apex fish oil, so it's very, very tolerable. And so people are so far taking it pretty well. Losartan, we start very low dose, 25 milligrams, increase to 50, which is really the standard therapeutic dose. If after 6 months we don't see interleukin-6 that is reduced, then we may increase to 100 milligrams. We didn't get there yet. Might be a challenge. I'm not sure how many will get there, but we're monitoring this very closely. So we look at men and women, 70 years and older, who have difficulty walking by self-report and have a walking speed of 1 meter per second, which identifies a high-risk group for future mobility disability. And they need to be able to have walk 400 meters, which will be the primary outcome of a major study. And have both slow walking and a high IL-6. And the question here was, well, maybe we'll find a high number of slow walkers, but very few would have high IL-6. And actually, it's not true. 2/3 of those with slow walkers also have high inflammation. So highly prevalent. Here again, there is a very strong correlation between inflammation and walking performance. Again, we want to see if we reduce inflammation if walking improves. So IL-6 is a primary outcome. Walking speed is also primary. We have a number of strength measure, number of biomarkers of inflammation we're measuring as well. So this is pretty innovative because targeting inflammation to achieve to improve mobility in older adults has not been done so far. I mean, I'm not aware of any study that has demonstrated this at this stage. This is a very high-risk population. These are typically people who are excluded from trials. If you look at the typical, diabetes, cardiovascular disease trials, prevention trials, they want people who have a disease, period. These are people who have high morbidity, and this is a very similar population we enrolled in the LIFE study. Typically they get one hospitalization, 20% of hospitalization per year. So it's a very high-risk group, and repurposing widely available and inexpensive intervention, I think, is an important factor. Yes?
So this is, do these people, have you measured blood pressure?
We do, of course.
Are these people that have high blood pressure in this group? Or?
No, actually, some are hypertensive. Actually, the prevalence of hypertension is pretty high. It's probably 60-70% in this group. But typically, if you add an angiotensin receptor blocker to a person who doesn't have high blood pressure, it doesn't reduce blood pressure more than that. Typically, we had few occurrences of hypotension, but not very frequent. So it doesn't add. It doesn't reduce, like, it's not a vasodilator that would drop your blood pressure, and so that's part of a safety aspect of this study. But the challenge is that this group of population has high prevalence of population, and they are already on losartan because it's the safest drug, most frequently used, or a similar drug. So we cannot take them off, and we cannot randomize them. We also test two drugs, see if both drugs interfere and have a potentiating effect, because they probably act through different pathways. And so we will also test our inflammatory markers in addition to interleukin-6. So we'll look at preliminary data. We'll design a much larger study. This works to look at the hard outcome, inability to walk 400 meters. That would be the large study. This pilot, which is pretty large, already works. Last study I want to talk is a metformin. I know it's a very hot topic, highly promising drug. I mean, a number of groups are looking at that. There is a plan to look at a large multi-center trial, look at metformin. It has effects on inflammation, cellular survival, stress defense, autophagy, protein synthesis, and ultimately, whether it increases longevity. We just discussed this morning, but in mice it doesn't increase longevity. But that's one of the goals of a tame study targeting aging with metformin. So we look at people with slow gait speed or obesity. I think this has been adapted. The last protocol is looking primarily at people at slow gait speed as a primary inclusion criteria. Primarily because older people have comorbidities, and so it's really hard to to stratify according to multiple diseases, and gait speed really summarizes the effect of multiple morbidities on function. Double-blind placebo-controlled trial look at the composite outcome: cardiovascular disease, including myocardial infarction, stroke, heart failure, revascularization, peripheral artery disease, cancer, MCI, dementia, death, virtually anything that could happen. And also we'll be looking at physical performance measure, primarily walking speed on a 6-minute walk. That will be the outcome. So, to conclude, totality of evidence brings us back to physical activity. It's the only intervention that really works on mobility. And life involves the most vulnerable older adults who are understudied, who are typically not included in large trials. It's a frail population, high risk. We demonstrated physical activity has a benefit on mobility as well as inflammation. Those at highest risk benefit also on other range of outcomes, as I mentioned, as cognition and cardiovascular disease. And it's an intervention that is cost effective. And I would just finish with this last slide, which is an editorial that appeared in the Annals with our last paper on physical activity, saying that prescribing exercise may be just as important as prescribing medication, perhaps even more important in some cases. And however, clinicians need training, tools, and support for this effort, and financial support. It is time for medical schools to start preparing students to prescribe exercise as effectively as they prescribe statins, and for health systems to support physicians in addressing inactivity, just as they support in addressing other health risks. And I think we're not there yet, but that's what we know so far. Thank you very much for your attention.